What does pancreatic cancer staging mean for you? Hello, this evidence-based content is prepared by Sabor Khan, fellowship-trained consultant surgeon. And if you or someone you care about has just heard the words pancreatic cancer, you're probably feeling overwhelmed, maybe trying to understand what terms like resectable, borderline, or unresectable actually mean for you or your loved one. I know this information can feel daunting, but understanding how doctors stage pancreatic cancer is crucial because it directly determines which treatment options are available. Before we dive into the specific staging categories, let's establish what we're dealing with. Pancreatic cancer staging isn't like many other cancers, where doctors simply measure tumor size. Instead, the staging for surgical planning focuses primarily on one critical factor: how the tumor relates to the major blood vessels near your pancreas, specifically the superior mesenteric artery and the portal vein. Resectable pancreatic cancer means the tumor is limited enough that surgery can safely remove it with clear margins. Here's the specific definition. The tumor has no contact with key arterial blood vessels like the celiac axis, superior mesenteric artery, or common hepatic artery, and either no contact with the portal vein or superior mesenteric vein, or contact of 180 degrees or less, without distorting the vein shape. In resectable disease, the tumor is sitting alongside these highways but not blocking or wrapping around them. This is the situation where only 15 to 20% of patients find themselves at diagnosis. If this applies to you, surgery offers the only chance of cure, and you're in the group with the most treatment options available. Doctors now increasingly recommend chemotherapy before surgery, rather than rushing straight to the operating room. This category represents what medicine calls the gray zone, and understanding it is crucial if this is your diagnosis. According to the National Comprehensive Cancer Network guidelines, borderline resectable disease is defined by specific patterns of blood vessel involvement. For tumors in the head of the pancreas, you fall into this category if the tumor has contact with the portal vein or superior mesenteric vein of more than 180 degrees. While these tumors are technically removable, attempting surgery immediately carries a high risk of leaving cancer behind, at the margins, what doctors call an R1 resection. Data shows that incomplete resection strongly predicts early recurrence and shorter survival. That's why most patients with borderline resectable disease receive chemotherapy first, sometimes combined with radiation to shrink the tumor away from these vital blood vessels. If you're supporting someone through this, understand that this initial treatment period, typically 4 to 6 months, isn't a delay. It's strategic downstaging that improves the chances of a complete curative resection. In one meta-analysis of borderline resectable patients who received this approach, 38% were able to undergo surgery, with 63% achieving clear margins, and a median survival of 23.2 months. Let me be direct here. Unresectable doesn't mean untreatable. This is crucial for anyone hearing this diagnosis to understand. Pancreatic cancer is categorized as unresectable in two main situations. First, if there are distant metastases, cancer spread to the liver, peritoneum, lymph nodes beyond the pancreas region, or anywhere outside the abdomen. Second, because of local blood vessel involvement that makes surgery unsafe or impossible. Approximately 30 to 40% of patients present with locally advanced unresectable disease and modern chemotherapy regimens have changed the landscape dramatically. Some patients, about 30% in one study of previously unresectable cases, responded well enough to chemotherapy that surgeons could subsequently achieve complete removal. This doesn't happen for everyone, but it demonstrates why aggressive systemic therapy remains vital. The gold standard is a specialized CT scan called a pancreatic protocol, or multiphasic contrast-enhanced CT scan of the chest, abdomen, and pelvis. This isn't your standard cord. It's a thin slice study done at specific phases after contrast injection to capture both how the tumor appears and its exact relationship to blood vessels. The sensitivity of this imaging for pancreatic cancer is high, 89 to 97% overall, reaching 100% for tumors larger than 2 centimeters. Experienced radiologists can measure the degree of vessel contact in degrees of circumference and assess whether veins are still reconstructible. This is why the imaging should ideally be reviewed by a multidisciplinary team, including surgeons, oncologists, and radiologists who specialize in pancreatic cancer. Let me explain why these blood vessel relationships are so critical. The superior mesenteric artery supplies blood to your entire small intestine and part of your colon. You cannot live without it, and it cannot be removed. The portal vein carries blood from your intestines to your liver, while short segments can be removed, and reconstructed extensive involvement makes this impossible. During pancreatic cancer surgery for borderline cases, about 30 to 40% require vein resection and reconstruction. Experienced surgical teams at high-volume centers can safely perform these complex procedures when the vein involvement is focal and reconstructible. The data shows that when done appropriately, vein resection doesn't worsen survival compared to standard surgery. However, arterial resection, removing and reconstructing arteries like the superior mesenteric artery, is a different story. Multiple systematic reviews have associated arterial resection with poor short-term and long-term outcomes, which is why there's currently no evidence to support it outside of clinical trials. The one exception is a specialized procedure called the modified Appleby operation for body of pancreas tumors involving the celiac axis. If you're worried about someone you love facing these decisions, understand that surgeon experience and hospital volume matter enormously. These are not operations for general surgeons at community hospitals. They require specialized teams at high-volume pancreatic cancer centers. Get your imaging to the right experts. If you've been diagnosed with pancreatic cancer, your CT scan should be reviewed by a multidisciplinary tumor board at a specialized center, even if you initially saw doctors elsewhere. The interpretation of borderline resectable versus unresectable can vary, and you want pancreatic cancer specialists making these determinations. Understand your timeline. If you have resectable or borderline resectable disease, there's time to make informed decisions. Unlike some cancers, an extra week or two to get second opinions and understand your options won't change outcomes. If you have jaundice, yellowing of skin, or eyes, biliary stent placement to relieve, it should happen quickly, but even that doesn't need to be immediate. Begin building your support system now. Whether facing neoadjuvant chemotherapy or surgery first, you'll need practical help. Identify who can drive you to appointments, help with daily tasks, and provide emotional support. Cancer support groups, through the American Cancer Society, specifically for pancreatic cancer, can connect you with others navigating similar decisions. Come to your appointments with these specific questions written down. What is my exact staging category, resectable, borderline resectable, or unresectable, and what specific features on my imaging determine this? Ask them to show you the images if possible. If I'm borderline resectable, what's your recommended sequence? Chemotherapy first or surgery followed by chemotherapy? What does the evidence show for my specific tumor location and blood vessel involvement? What is your hospital's volume of pancreatic cancer surgeries per year, and what are your outcomes for margin-negative resections? High-volume centers perform at least 15 to 20 pancreatic cancer surgeries yearly. Top centers do many more. Do you routinely perform vein resection and reconstruction during pancreatic surgery? What percentage of your patients require this? You want a team experienced with complex vascular reconstructions. If my disease is unresectable now, what's the possibility of downstaging with chemotherapy to make surgery possible later? How often does your team see this happen? This gives you realistic expectations. Should I have genetic testing for germline mutations? Would this affect my treatment options? National guidelines now recommend universal germline testing for all pancreatic cancer patients, regardless of family history, as it may reveal targetable mutations. Rapid weight loss or inability to eat. If you're losing more than 10% of body weight or can't maintain nutrition, you need intervention. This might include pancreatic enzyme replacement dietary counseling or addressing gastric outlet obstruction. Malnutrition before treatment worsens outcomes. Your staging category, resectable, borderline, or unresectable, depends primarily on how your tumor involves critical blood vessels, and this determines your initial treatment path. Your next step: ensure specialists in pancreatic cancer review your imaging and discuss whether you're a candidate for surgery now after chemotherapy or need a different approach entirely. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. Thank you for watching.